It's exciting to come to an audience that is still asking questions. And that was really important to me because the reason I wrote the book is because some of our institutions had stopped asking questions. And I had been part of pandemic preparedness for decades. I had seen all of the desktop exercises. I had seen all the plans. I had seen all of that. But then for the last 20 years, spent the time on the ground battling pandemics community by community of HIV, TB, and malaria. And I think what we missed in the United States is the response. We had a plan. But when the plan didn't have the response that we needed, it caused great confusion in January and February. And I think when that happens, you can either be like you all, have an open mind and say, this isn't working, what can we do? Or you can dig in and say, no, daggone it, we're gonna make that plan work. And we dug in as a country and said we were going to make that plan work. And the reason I wrote the book was to really point out to people that if we don't fix this institutional groupthink, we're going to continue to have this problem. And if you saw what happened with monkeypox, so here we are in January and February of 2020 with COVID-19. I am working in Africa on HIV, TB, and malaria. We have our annual meeting coming up. I am a data-driven person. And so every year we would bring community and ministries of health together and say, here's what's working in combating the epidemics on the ground, here's what's not working, and here's the gaps. So I'm preparing for that, but I'm seeing the social media feeds about the pandemic. It's still not being picked up by mainstream media yet. And I'm watching this carefully, and I got so concerned, I went to the NSC, which was probably my mistake, because then they got to know who I was. Went to the NSC and I said, can we convene a meeting of all the African diplomats in Washington, D.C.? Because I am so worried about this, because as Patty said, when SARS hit in 2003, almost no China nationals were traveling. I knew with COVID, because I had been working globally, that tens of thousands times more Chinese nationals were traveling. And we were just at their most critical holiday. And I knew that virus was everywhere. So I got the NSC to convene a meeting of all the African diplomats at the White House, because everybody will come when it's at the White House, something I learned when I started working at the White House. So all the African diplomats came in January of 2020. And I said to them, yes, I run a $6 billion a year program, but use all of our resources, all of our human capacity on the ground, all of our laboratories, all of our clinics, and get ready for this pandemic, because it is going to be very bad. And then I started watching the US news conferences with our institutions saying that the pandemic could be contained and that we could follow it by symptoms. By symptoms. Now, can you imagine going to your doctor and saying, I'm peeing a lot, I really feel dehydrated, I'm not feeling great, and your doctor says to you, I think you have diabetes. I'm going to treat you with insulin. And you would say, what, you're not going to do any lab tests? You're not going to try to figure out what this really is? No, I just believe you have diabetes, I'm going to give you insulin. That's what we did with flu for the last 50 years. And that's what our pandemic response was based on. We were going to track people by their symptoms. In a day and age of the 21st century where we have technology and DNA technology, RNA technology, where we can diagnose every single infectious disease that you could possibly have on any given day, and we're going to track you by symptoms. And so if you remember, when people came back to the country from China, they were given a form, no matter where they came in from, and it said, come back to us if you have symptoms. Well, I knew in that moment that COVID was everywhere because I had been following the social media, and you don't build a 1,000-bed hospital overnight in Wuhan, China, if you don't need a 1,000-bed hospital immediately. But you don't have that level of hospitalization unless you have unbelievable asymptomatic spread. So I knew at the beginning that there had to be a whole group that got very mild disease that were the spreaders. Because let's face it, when you're sick, you're not engaged in social enterprise when you're that sick. So if you're so sick that you're being hospitalized, you're not spreading virus. So there had to be spreaders, and then there had to be people who were really sick. And we decided that we were only going to look for the really sick people. And we were just going to let all of the spreaders spread virus across this country without any laboratory diagnosis. And so that was our original magical thinking. For decades, we believed that pandemic response was containing viruses and pandemics somewhere else off our shores. And we believed that was possible. And that's why we didn't prepare as a country in a way that was going to be successful. None of the pandemic preparedness plans included connections with our clinical care facilities or our laboratories, our commercial laboratories. There were no plans for data stream from hospitals or clinical labs. There was only plan for the surveillance system based on symptoms and our public health laboratories. Now, how many of you in this audience, and I know you're a very well-informed audience, know where your public health laboratory in your state is? How many have you been to them? Okay, because people don't go to public health laboratories to be diagnosed. In case you're not wondering, that's not our healthcare system. That may be the healthcare system in other countries, but it's not our healthcare system. So we needed a system for us, and we didn't create that. Now, pandemics create amazing inflection points. HIV/AIDS created an amazing inflection point in that it spurred immunologic discovery forward in a way that we had never seen before. And it allowed us, if you hear today about immunotherapy for cancer, all of that came out of the HIV research. So we're seeing real implications from the inflection point of this pandemic, particularly in the United States, about people wanting to be empowered to know what they have and know what they have in real time so that they know what to do, so that they have the power and knowledge to know what they need to do for themselves, and then the ability to do telehealth so that you don't have to wait in a waiting room for 4 and 5 and 6 hours. And so people now are saying, why didn't we have this all along? Because as Patty said, we had the technology. We weren't using it. We weren't using it to really meet the needs of our patients. But COVID is more importantly changing the work environment and employee expectations. Now, I have a whole family of millennials. And I can tell you every one of my millennials believe it's the employer's responsibility to create a safe work environment. Safe psychologically, safe from their mental health perspective, and safe environmentally. And if you want people to come back to work with confidence, they're going to expect you to demonstrate with data, not perception, that their workspace is safe. They are data driven. Because they're used to doing all those searches on the internet, deciding which data is real and not real, and making their decisions about what cleaning supplies to buy for their household based on all that information. I mean, they consume data in a constant stream. So they're going to want to see what you have to prove to them that their workspace is safe. Now, I don't know why China has a zero COVID policy, but I think it is a lot more than just preventing very sick people from going to the hospital. I think that they saw from that original data how severe long COVID is. And I think that with the situation they have with their workforce because of the zero child policy from 40 years ago, and having such a diminished workforce, they realize that they cannot take a hit of losing 5 to 10% of their workforce from long-term COVID disability. And as a country, we're ignoring that. That somehow chronic fatigue is not a problem. Now, chronic fatigue syndrome is a problem, but it is nothing in the numbers like we're seeing with long COVID. And so much of the country has focused on acute disease, but our long-term problem from COVID is also going to be long COVID because of its devastation in the 20 to 50-year-old age group. So what have we learned? Number one is these surges are predictable and they occur in a very distinct geographic pattern, and 100% of the variants that came to the UK came to the US 2 to 3 weeks later. So it's not like we don't have an early warning system. We do, because the UK has been doing a great job with testing and a great job with sequencing their variants, and they tell us and we know, and every time you'll see the media say, well, I think this time it's going to be better. I think this time less people are going to die. I think this time Delta's going to be milder, or this time Omicron's going to be milder. We're not going to have to worry as much. But they didn't go and look at the data that produced that information, and I'll talk a little bit about that. Thirdly, which is really important for everybody and every American to understand, is our current vaccines cannot produce herd immunity in the way that we think of herd immunity, because the vaccine itself was never studied to protect against asymptomatic disease or even mild disease. In the clinical trials, you had to say, I have symptoms, and come to the clinic and get tested. We did no proactive testing in any of those phase 3 trials for the approvals of these vaccines. So we never studied the vaccine's impact on infection. And after, I will tell you, after the Clorox moment, which maybe you might remember, I vowed that that would never happen again. So whenever I had access to the president, so in July of 2020, I said to the president and did a whole briefing on there is a difference between sterilizing immunity and protection from severe disease. And we're only studying protection from severe disease. So don't ever say to anybody at any time that these vaccines can produce sterilizing immunity. Now, there are vaccines that do. And the vaccines that do, and I'm going to talk a little bit about them because you have got to be the group that goes out there and informs the workplace about these different vaccines, because you need to really understand them. This COVID, the vaccines are designed by tracking natural immunity. In case you wondered, how do scientists figure out how to make vaccines? We look at what natural immunity looks like, and that's what we try to reproduce. This is why we don't have an effective HIV or TB vaccine to date, because natural immunity does not prevent progression of disease or reactivation. So the current vaccines that we have, measles, mumps, and rubella, diphtheria, tetanus, and pertussis, so your MMRs, your polio, particularly the OPV polio, as opposed to the IPV polio, that may not be quite as exclusively protective against infection. OPV was. Those are live attenuated vaccines, are vaccines made to specifically mimic natural infection. And natural infections, for those of you who are my age in the audience, and I won't ask, but if you got a smallpox vaccine, you're my age in the audience. You also may have some prolonged protection against monkeypox. So be glad you're over 50 and born before 1970. But if you got mumps or you got chickenpox, you know that you didn't get it again. And our moms were smart enough to say, you go over there and play with Tommy, he has chickenpox. Let's get the whole household have chickenpox all at once, because we're not going to have chickenpox for the next 6 weeks, because then you can't go to school. So, you know, moms were smart in the 50s and 60s, and we all got our chickenpox almost at the same time, and we were protected for life. That produces herd immunity. COVID infections, and we knew this by December of 2020 when we saw the second large outbreak in South Africa. It was clear that COVID prior infection does not protect against reinfection. that immunity wanes over time in the protection against infection. In South Africa, we have very good data now. Over 4 to 6 months, immunity wanes. A new variant. The new variant is partly immune escape, partly your diminishing immune response. So that's what happens. And once you saw that, you knew that these vaccines were not going to protect against infection for long periods of time. And that's really still protecting against severe disease and bad outcomes. But now you've got the whole American people saying and questioning, why did you tell us it protected against infection? Well, what about these other vaccines? So now you've created, because you weren't absolutely crystal clear to the American people, and this is going to be your job. And I worry about poor Patty now, because now it's all on you all. Because now the expectation is you have the tools to define whether a building is safe or not. Are you using them? And are you telling people that these policies and technologies need to evolve to protect these spaces? So that's a huge threat now, because people are going to have expectations that you see the problem, that you've measured the problem, and you're going to remedy the problem. And when Americans believe that they've been misled, it's very difficult to reestablish trust. Every single pandemic that I have worked on has misinformation. The president of South Africa told people that garlic and herbs would cure HIV. This is common in pandemic, because when you don't have what you need to save people's lives, you hope for something else magical that might. It's just human nature. We want things to be better, but you can't leave science and data behind, and you have to really move into the 21st century. Now, what I do worry about, and I will say to every one of you, please get the Omicron booster in the fall. I think it's going to be ready. With the UK already approving it, that usually generates motion in our industries and in our agencies. So I'm sure we're going to have approved Omicron variant vaccines by at least middle to end of September. Please get that, because what we did see with Omicron in January, even in people who were boosted in October, is hospitalization and deaths, particularly in people over 70. So please get the boosters. So just a real quick vaccine 101. Not all vaccines are alike. To control, eliminate, or eradicate infectious disease threats, you need to produce a vaccine that causes herd immunity. That's what we did with polio. So we've really decreased polio. That's what we did with measles, mumps, rubella. So that's how we've worked to create herd immunity through these vaccines that create long-lived immunity. And as I said, vaccine development relies on natural infection. So if natural infection doesn't induce long-lived immunity, it's hard to do better than nature. It really is. I spent 4 decades working on an HIV vaccine. It is hard. It's hard to do better than nature. No one with HIV has mounted an immune response that has cleared the virus. The only cases of HIV clearance has come from people who have had complete bone marrow transplants. So, obviously we can't do that on a scale of 35 million people around the world. So when you don't have a roadmap of what to do, it makes vaccine development much more difficult. So I just wanted to give you this data really quickly so you could see. I brought up measles because we do have pockets of places in the United States where measles immunization is very poor. What annoys me at times with the CDC is they'll give you a national level data. That's irrelevant to you. What you want to know is how well immunized is your county, is your community, because that will determine whether you have a measles outbreak or not. I show you the world data so that it's very clear that the measles vaccine produced herd immunity, and in the United States and the world, we've had very little measles for more than a decade. But to remind you, before, we did have 3 to 4 million children who got measles every year, and a significant number of children, of course, were hospitalized, but about 1,000 died from encephalitis. This is what measles herd immunity looks like. We've done long years of follow-up, and we know it lasts at least 10 years. So this is what, if anyone says to you, what about the other vaccines? These vaccines do produce long-lived immunity that results in long-lived protection. And so the polio, this is now polio and polio case and death rates. For those of you who were born in the 50s and 60s will remember the sugar cubes. You'll remember then the breakthrough of the injection. And this was the Salk-Sabin argument for decades. For those of you who were trained in immunology, it was very exciting to see both of them at meetings because they would really go at each other about their vaccines. But we had two vaccines and it was great, and they were both highly effective. And we've seen very little polio, and we've seen no polio deaths. And this is paralytic polio by region. Very similar to measles. So you can see exactly the same pattern of decreasing cases of paralytic polio around the globe. Now you see that little blip in 2021? That should concern all of us because because of so many things being shut down, a lot of these immunizations are done as immunization campaigns where entire villages are immunized at once. A lot of those campaigns didn't happen. And so I am concerned globally about the rate of immunization and what could happen over the next couple of years. Smallpox, I'm bringing this up because everybody now knows about monkeypox. The pox family is fairly cross-reactive. So those of us who got smallpox vaccines probably have some residual immunity to monkeypox. So it's like the reverse of COVID. We're protected, you're not. So if you're under 50, please really consider potential exposure because as opposed to COVID, monkeypox and smallpox and all the pox viruses can live in linens and towels and surfaces for long periods of time. And much more difficult to kill than many of these other viruses that we've talked about. But you can see the rate of smallpox in the United States. That's that first navy blue bar. And sometimes we forget how much the United States had of smallpox. And then I show you India so you can see India's rates, which are also now very low. So what about COVID-19? So just to reemphasize again, natural infection with COVID-19 does not result in long-lived immunity against reinfection. And it doesn't look like prior infection protects against long COVID. And the risk of long COVID increases with every infection that you have, including mild disease. So where did I get this data? And I think this is really important that you have people integrating global data. The other thing that United States suffers from terribly is not willing to really learn from other countries. I can tell you I've worked all over the globe. There are smart scientists and clinicians in every country I worked. It doesn't matter what the country is. And we should be talking together and learning those lessons that other countries can teach us. And South Africa, which did an extraordinarily good job of testing, they had more data on how much of their population was infected than the United States did. So they went out and they did community-based surveys, and they knew with that original SARS infection that between 30 and 70% of community entire populations were infected in that first go around. They went and did the same thing with the beta variant and found the same thing. 70% of the communities were infected. So it was clear to them that natural immunity wanes. And if you look at the periodicity of this, it wanes every 4 to 6 months. And South Africa has had a significant COVID outbreak every 4 to 6 months for the last 2.5 years. And so this is our roadmap of what our natural infection can do, what our current vaccines can do. And we should have no expectation that our current vaccines are going to provide absolutely sterilizing immunity. And so you're going to continue to have community spread. And then how are we going to protect those who need those most? So what about severe disease, hospitalization, and death? So when I came into the White House on March 2nd, I came in, of course, with a list of things we needed to do. And I have to say, they did mobilize. I was used to calling for meetings, and I called for a meeting I said, I need all the commercial lab developers to come to the White House, and we need to tell them we need tests within the next 2 weeks. And I was expecting the scientists, so I walk in the room of the lab developers, and it's all the CEOs. I was like, oh, I didn't expect you to come. I expect your developers to come. But when you call a meeting in the White House and they think the president is going to be there, the CEOs come. But those CEOs immediately mobilized, and we had tests from every major commercial developer within the next 2 to 4 weeks. Imagine if we had done that in January. Imagine if we had said, we're not going to look for just symptoms. We're going to get ready, and we're going to have all of our commercial laboratories ready with these tests. Instead, we had them ready 3 months later, and it cost a lot of American lives. But when I came in, because I had worked globally, my European colleagues were sending me their data. And they were in the midst of a really horrendous time. If you remember those early pictures from Italy. And Italy shut down on March the 8th. But before March the 8th, they were sending me their data by age, by sex. And so I could take into the White House that the people most susceptible to this are people over 70, and they're dying at an enormous rate. An enormous rate. And so at that very moment, that first wave, 30% of people over 70 that had cases died. 30%. Now with innovation, and so that's why we needed to do the shutdown at that moment. We didn't have anything else. We had no countermeasures. We didn't have masks for the public. We didn't have tests for the public so that they could know that they were infected and quarantine and isolate. We didn't have anything, and we didn't know how to treat it, and we had no antivirals because we hadn't used that time in January and February to create antivirals because we thought we could contain this virus off our shores. So that's why you take drastic measures, because you have nothing else. That was never going to be the long-term solution to this problem, but it was a crisis, and it was the only thing that we could do in that moment. And we only had, and I say only, about 10 metros go down. And that's why we ended up with just about 100,000 people dying in that first 6 weeks. If 25 metros had gone down, we would have had deaths over 500,000. So when they say the American people didn't respond, they actually did. And I think one of the biggest mistakes we made is we never went out and thanked people, because that original surge could have been far worse and far more areas of the country. But people really did change their behavior. If you look at mobility data, even in Iowa, it decreased 50% or 30%. So people did hear the message and enacted and really prevented that first community spread. And from that moment on, we really worked on developing countermeasures, particularly testing, because knowledge is your gateway to understanding whether you're infectious and whether you can infect others. Now, a lot of people say things are getting a lot better. I wanted to just let you see this data. Despite vaccines and Paxlovid, monoclonal antibodies, remdesivir, and all of our very effective tools, we will probably have 300,000 Americans lost this year, despite all of our countermeasures. And that's about 820 a day. We're losing about 500 a day right now. We'll probably get to around 600 per day because the individuals are just peaking hospitalizations across the South. And so we will lose a significant number of those individuals that have been hospitalized despite our countermeasures. And so, yes, we have 37% deaths than last year, but our annual flu deaths are about 35,000. That was, now I say about, because we have no idea because we weren't diagnosing flu. So if you go to the flu surveillance site at the CDC, that's all modeled. All modeled, because 90+% of flu cases are never diagnosed laboratorily. And we're in the 21st century. So when I went to Africa, that's what we were doing in Africa with fever. That was 1990. And we didn't know whether you had HIV, TB, or malaria. So what did we do? We treated you for one versus the other until your fever went away. Well, that wasn't effective. That often took 4 to 6 months. So one of the first things we did was make sure we got testing for HIV, TB, and malaria. So we had a definitive diagnosis of what that individual had. Yet in the United States, we were pretending that's what you had. And we didn't know whether you had flu. If it was flu season, we said you had flu. If it was adenovirus season, we said you had adenovirus or mycoplasma pneumonia or parainfluenza, or we said your children had RSV, but we didn't know. We just pretended that's what you had. At a time when we could tell you, can you imagine if you went in to your doctor and your doctor said you have cancer, so we're going to treat you for cancer? In the 21st century, we can define the exact tissue type of that cancer and match that to exactly the type of therapy that you need. Yet when it came to infectious disease, we just accepted that that's what they thought I had, so that's what we're going to accept that I had. In the 21st century, we weren't diagnosing infectious disease. And I think you could hear that when Patty was talking about workspaces. You know, we were concerned about particulates. We were concerned about smoke. We didn't have people smoking in the workplace anymore because of secondhand smoke. We evolved when it came to environmental pathogens, but we were not taking that same approach to infectious diseases. And I think we all have to ask ourselves why. Why did we take such a blasé approach, particularly to viral infectious diseases? And that's why we don't have antivirals, because I can promise you, if you don't definitively diagnose it, you can't definitively treat it. And then no pharmaceutical company wants to have to do clinical trials where they have to do all soup to nuts, diagnose plus develop the antiviral. You know, they want to be able to go into a clinic and know who has flu and get them diagnosed early, not have to pay for that part and just do the clinical trial. Now, you all know this, but it's really important. COVID reacts to people differently depending on their age. So this is the reverse of monkeypox. Those of you who are over 60 are at risk for significant disease. And if you do get infected despite being vaccinated and boosted, you should get Paxlovid. You should get what the president, what Jill Biden, what Tony Fauci, and what all of them have taken. But you have to be diagnosed early. So this is why testing becomes quite important, because the time you have severe symptoms where you think you need Paxlovid, you're probably past the 5 days. So really being aggressive on testing. The 35 to 60-year-olds, it really depends on your underlying comorbidities. And for people less than 35, the biggest risk really is asymptomatic spread in the workplace and long COVID. And really understanding which group people are in and what that workplace looks like becomes really quite critical. Now, this is the most recent data on hospitalizations. These are daily admissions. For those of you who love math and science, I was a math and PChem major, so I love it. If you look at the area under the curve, you should be a little concerned, because the area under the curve for this summer surge is higher than the area under the curve for last summer, because it's been more persistent, because we went from B2 to B5 very rapidly. And so the upper northeast surge of the early spring bled into the summer surge across the south. And so our hospitalization rates are still about 80% of what they were last summer. Now, you have to know what's happening in your state and your county, because right now the media is saying cases are going down and hospitalizations are going down. Yes, they're going down in some large population states like California, which skews all the rest of the data and hides the fact that hospitalizations are rising in South Carolina. And so I call it the tyranny of averages. National data is not really helpful when you're trying to make workplace decisions. I just want to cover really quickly what's happening in rural America and our tribal nations, because I've been a little bit upset with the media that will put up a state and say, these people voted for Trump and that's why their mortality is higher. Their mortality has been higher for the last 2 decades, and that may be why they were trying to vote for something different, because they had been abandoned for years. when hospitals, so we have about 6,000 hospitals, but only about 150 hospital systems. So when hospital systems bought up community hospitals, they often closed community hospitals, and they closed them in the rural South. And they closed them in our heartland. And what they said was, when you get really sick, we'll airlift you to the hospital. But I can tell you, when I got to Louisiana, to Our Lady of Mercy Hospital with the surge, they were full. So the community hospitals could not send their sick patients to the referral hospital. And so people died at a much higher rate, but they've been dying at a higher rate in the rural areas because they're older, they're poor, they have higher comorbidities, they have less access to primary care and much less access to subspecialty care. So these are just some quick data. The green lines are people who are older, and you can see that a significant number of Americans are older, all the way up to 85, and then it kind of equalizes between urban. Urban areas are enriched for young people, higher risk for monkeypox, lower risk for severe COVID. Rural areas, higher risk for COVID and COVID deaths. This is poverty. This is 50% children, 50% of the children in poverty in that dark, dark, dark area. So these are really communities and counties that have extraordinarily high poverty rates and comorbidities. And if you looked at our current summer surge, you would say, oh, this looks like our COVID surge. This is obesity. And we know that obesity is one of the biggest risks because it puts you at risk for diabetes and hypertension, which then creates that greater risk for severe COVID disease. So this is our obesity in the United States. And this is one of those graphics that's really should be a wake-up call to all of us. This is what I'm talking about, subspecialty care. I'm just using a surrogate level 1 and level 2 trauma. This is access within 60 minutes by ambulance or helicopter. And you can see that a majority of our geography does not have access to sophisticated subspecialty care. And this has been going on for decades. And this is 2014. This is all-cause mortality, age standardized. So if you're 70 in an urban area or a county versus 70 in a rural area, I call your attention to all that yellow and orange. Those are our tribal nation and our rural counties. So they have been dying at a higher rate at all ages for decades. And we've done nothing about it. And so this is my other reason for writing the book. We can't just keep collecting data, publishing data, putting it on our website, as the CDC does, and then not have an action plan that says, this is what we're going to do about this. This is what we're going to do in the next 12 months. This is what we expect the outcome to be. Can you imagine a business that had outlets that weren't selling cappuccinos and then just kept saying to their stockholders, well, that's okay, we're just measuring how many cappuccinos they didn't sell. And so, yes, these are our high sellers, these are our low sellers, but we're just keeping them all going the same because we're just measuring it. No, data has to lead to action and a plan, and then forcing accountability to outcomes. That's what we did for HIV in the last 7 years, and we went from 6 million people on treatment to 20 million people in treatment on a flat budget because we looked at every single thing we were doing and we said we have to change to save people's lives. Right now, in this moment, we have to change to save American lives because what we're doing is not working enough. I wanted to end, and I'll show you a quick, just to remember where you were for the last 2 years. And when people say these viruses are less deadly, the Delta surge of last summer was 40% more deadly than the summer surge of 2020. Now, the Omicron surge of this winter was 30% less deadly. We had more tools, but it was still significantly deadly. So we've lost 110 Americans since January. 210 Americans since January. That's why I think we could easily get to 300,000. Now, why did the media think the Omicron and Delta variant would be less deadly? Because they looked to the UK. And it was less deadly in the UK. It was 60%, Omicron and Delta together was 60% less deadly in the UK. Why? Because they were testing at 4 to 5 times our rate and they made it free, and every single Brit could walk to their corner, whatever, gas station, pharmacy, pick up a test. And they said to the British public, before you see grandma, before you see your great aunt, get a test. Right before you walk in. We'll give you as many tests as you want. Free. And although we were on par with them through January of 2020, look what happened afterwards. So Great Britain continued to expand their access to the population to have knowledge about whether they were infected or not, whether they had symptoms or not. They could get a test, they could have that knowledge before they went to see grandma, and they had 60% less fatalities. Nothing else was significantly different. So these small things can make a huge difference. And then finally, long COVID. The problem right now is a lot of things are lumped together. So if you're hospitalized with COVID disease, you could have a prolonged recovery period. So that's lumped in with the people who have mild disease and end up either from an immunologic reason because your immune response was too much, or because your immune response was too little and you continue to have pockets of viral replication. We don't know yet, but all these things have been lumped together. They need to be teased out so that we can have actions for each one of these. Now I'm going to end with where you've been, just to remind you all of what our last 2.5 years have been like so that we can change our future, because we do have 21st century technology. I'll deviate for 1 second and tell you what Governor Ivey said to me. And I loved Governor Ivey because she was a very practical governor of Alabama. And when people say the Republican governors didn't mitigate, I can tell you every Republican governor across the South, including DeSantis, allowed for local or statewide mask mandates, closing of bars in 2020, and decreasing indoor dining, expanding outdoor dining. And Governor Ivey did all of those things, including a statewide mask mandate. But she said to me, you know, I tell my population that it's like Swiss cheese. So you got that first piece of Swiss cheese with all those big holes. And so, yes, that first effort does change things a little bit. But if you put another piece of Swiss cheese on top, you've decreased the number of visible holes. So that's your second level of mitigation. And then if you put on that vaccines and boosting, that third piece of Swiss cheese, you don't have any holes anymore. And this is practical information that people can understand. So layered mitigation is critical, including layer mitigation for indoor air, because getting people back in mask is going to be really difficult. Not difficult for me because my family all still mask. No one over 40 in my family. There's 10 of us have ever gotten COVID. But we do mask quite a bit. And we do go to dinner parties masked, which I think does make people a little bit nervous and irritated with us. But I have a 93-year-old mother living in our multi-generational household, so I cannot afford that she gets infected because I know that she doesn't have a successful immune response to that vaccine. Let's just be clear, our T cells and B cells are about as bad as our joints when we're in our 90s. And so when our skeletal system is going, our immune system is going too. So people in their late 80s and early 90s probably do not have a completely effective immune response to that vaccine. So this is where we were in April 2020. The virus was quite limited to specific metros. That big blob you see in Georgia, southern Georgia, that's Albany, Georgia. That was that funeral outbreak. You can see the isolated meatpacking plant county outbreaks in this, and you can see the tribal nation, particularly the Four Corners area of the Navajos and other areas throughout Utah, Wyoming, and Idaho. Those were very often tribal nations. And you can see how bad it got into the tribal nations. To this date, the ethnic group that has the highest fatality rate is our tribal nations. In May and June, things started to improve, and then we had the summer outbreak. And we have the summer outbreak because it gets so unbelievably hot in the South that it's like winter in the North. People move indoors constantly to be in air conditioning. That caused that significant surge. We cooled really early in September of 2020. It was already freezing in North Dakota by the end of September. That initiated the winter surge that continued to build until post-Thanksgiving. We had an extraordinary surge. And again, that starts to improve in January and in February and in March. And then you have that summer, spring, that's late spring surge. This was the alpha variant last spring. That then moves into an improved May, and then you'll often hear the media say, oh, we're done with COVID. Things are great now. We don't need to mitigate anymore. And then the summer surge comes, that's July. That then precipitated the winter surge, which went into September, October, November, December, January, and then improving in February, improving in March, just like the March before. April looks just like April of 2021. And now this is the Omicron B2 variant in the upper Midwest and the Northeast, which then results in the summer surge where we are right now in July and August. And the question is, what is going to happen in the fall? But now you've been warned. So testing, vaccine, masking, or really doing something about indoor air. I can tell you, my small grandchildren, it is hard to get a 2-year-old to mask. And they send you pictures from the preschool, and the mask is always on the floor. I'm like, do you see those 2 children in masks? Why aren't I was the COVID coordinator. Why can't my grandchild be the one in the mask? She is just not, that 2-year-old is not keeping that mask on. So I think we just really have to be aware of the situations our children are in and really make sure that we're bringing all of the tools that we have, but more importantly for your group, asking the questions and forcing the policy change. Because I can tell you right now, our institutions are remaining 2 to 3 to 4 months behind and only acting in a crisis. They were behind in monkeypox testing. They were behind in monkeypox vaccination. We could have stopped this. I can tell you, every gay man would have been willing to be vaccinated. And every gay man would have said, tell me what I need to do, and I'll do it. And they would have, because they are very astute. They have great knowledge about immunology. They have great peer outreach. They have been working together for decades to limit HIV. They know how to do this. If they had been given clear instructions of saying, we think we've got monkeypox, it's a problem, it came right after gay pride, we think that it's in the community, limit skin-to-skin contact over the next 2 weeks, everybody get vaccinated. But we didn't do that. We limited testing again to our public health facilities. No gay man knows where his public health lab is. So, I mean, finally it's getting commercialized, but only in 5 laboratories. I mean, we're doing exactly the same thing we did with COVID, because in our minds, we just believe we're better and we can contain it. And now we've had example that we're not good with containing. So we have the 21st century tools and the knowledge to ensure that every American is safe from hospitalization and death. We have the ability to do that today. But we're not treating every hospitalization and death as a failure of our programming. And until you do that, until you say to yourself, I don't accept someone being hospitalized and dying from COVID, you don't fix the problem. So getting complacent and saying, oh, it's, the fact that the White House was even discussing how many deaths a day we would accept as Americans, if I had taken that approach in sub-Saharan Africa, if I had said to young women, yes, you're the highest risk for HIV infection, but, we're just going to accept that you're going to get HIV. That you don't change pandemics by accepting that anyone gets severe disease or get infected. Your goal has to be 0. And that's the only way you get close to that goal, because anything less than that, you're not programming optimally. And so we do have these tools between vaccination and boosting and testing and masking. But we also have the tools that change our indoor air when it comes to infectious diseases. And as a group, I'm really hoping what you do, because I'm very worried about long COVID. I'm worried about the depression that comes from constant brain fog and fatigue. When you know your brain isn't working right, it's not good. How many people in this room have been jet lagged from flying to Asia? Okay, remember what that's like. You're like, my children know what it's like. That's when they asked me for everything they've ever wanted. And of course, I just said yes, because I was so exhausted. So they learned, jet lag, get everything you want from mom, because this is your moment. So, you know, imagine feeling like that every day. And that's how they feel. And we have to take long COVID seriously, even if our federal government isn't. Because I'm going to say the same thing to you that I said to governors all over the country and mayors. You may think you're getting away with this right now, but I can tell you this is a historic event. It will be studied for the next 100 years. People will look back and say, they had the tools to do this better, why didn't they? What went into their decision making? Why didn't they prioritize our safety over profit? Why didn't they change just the same thing that people have done with tobacco? Of why didn't we warn Americans about how deadly tobacco was and how deadly secondhand smoke was? I think people are going to come back and say to us, you had all the technology and all the ability to collect the data to make sure indoor spaces were safe, and you didn't push that agenda. And just as we're pushing the climate change agenda and the organisms that are going to come out of climate change, and we're warning people about it, you are the body that needs to start warning people about what it's going to take to control this virus, both from the infection standpoint and the severe disease standpoint. Because I believe that if you want economies to thrive, you want your children to thrive, they really want to know that you're taking care to make sure we all survive, and then we all thrive together, and not using the technology that we have today. There's always misinformation. There's always poor communication. Stop talking about it. Get on the ground. Get in those communities. Answer their questions. Listen to their concerns. And explain it one American at a time if that's what you have to do. Stop the pointing fingers and saying, well, they voted for Trump and they can't understand this. They can't understand this. We can't keep making excuses for our failures. And so that's why I wrote the book. It comes with an appendix of what Congress needs to do, because I believe CDC needs to be in the field. They have 10,000 people, put 5,000 in the field. Move from planning to helping states implement these programs, community by community, based on those community needs. That's what will change. Get people into the workplace and get all of our environmental EPA people out there helping organizations to understand what their risk is in their indoor air and doing mitigation that shows definitive impact. Not something done in the laboratory, but something done in real life. And that's to be honest, it's why I could have gone to many companies. I went to Active Pure because they were willing to do the science. I said to them, we got to move past the box and the lab into spaces and show impact and outcome changes. Because in the end, we want to decrease absenteeism. We want to give people the confidence that their workplace is safe. No one would walk into a smoke-filled room today and feel good about it. Yet you're asking people to walk into virus-filled rooms that they can't see and telling them it's okay. It's not okay. And unfortunately, you're the intersection of that. And I can't tell you how much I appreciate the dialogue that you had yesterday, because it gave me incredible hope. And I want to thank Patty for setting up that kind of open space where people have the confidence to say what's on their mind, because that's the value of getting together. That will trigger something in someone else's mind that will change thinking forever and how we move forward together. So I was very impressed by your willingness to challenge each other and to talk in an open space way, because that's how we're going to change things in the country on many different levels, including our political level. That if we start listening and realizing that, someone else could have a great idea, and it doesn't matter how they voted, that determines whether they have a brain or not. And so I think we just have to get past all of that. And I think you're the group, from what I heard yesterday, because I know you come from many different walks of life, and I don't know how you voted, but you seem all very different, yet you were willing to be in dialogue. And I think that's really quite extraordinary.